Slade and I'm Head of Storage and Digital Collection Services here at the State Library. It gives me great pleasure to welcome you all to the policy pitch. Tonight's topic is Getting Primary Care Right. This seminar is held on the traditional lands of the Kulin Nation and I wish to acknowledge them as the traditional owners. I would also like to pay my respects to their elders and to the elders of other communities who may be here this evening. I'd like to give a warm welcome to tonight's speakers, Anne Congleton, Dr. Stephen Duckett and Jane Gunn, as well as our moderator, James Button. I'd also like to welcome Grattan Institute members and staff and friends of the library. We are really delighted to present the Policy Pitch series in partnership with Grattan Institute. All of Grattan's reports and most of their events are free and can be viewed online. And as Head of Storage and Digital Collection Services, I'm pleased to say that these seminars and related reports are being added to the library's digital collections for future use by researchers. Last week, along with libraries across Australia and New Zealand, we held Born Digital 2016, our inaugural Digital Preservation Week. This explored questions around collecting and preserving digital content, raising awareness of the importance of preserving it for the public good and as a record of 21st century history. It's in fact 25 years, almost to the week, since the first public website went live. Digitally created material has expanded exponentially and replaced a huge number and variety of physical records. Libraries such as State Library Victoria are working hard to ensure that this information doesn't disappear, and I encourage you all to view some of our recorded interviews on the library's website. As Victoria grows and technology transforms the way we live and work, the library is constantly evolving to meet the changing needs of the community. And like the library, Grattan Institute is community-minded and forward-thinking. They provide independent, rigorous and practical solutions to some of the country's most pressing problems. They run 7 policy programs in areas vital to shaping Australia's future, and tonight we'll hear about the significant policy area of healthcare. Anne, Jane and Stephen, I'm looking forward to hearing your expert opinions about getting primary care right. And I'm pleased now to introduce James Button, tonight's moderator, who will introduce the panel and lead the discussion. James worked for many years as a reporter and editor at The Age, both in Australia and the newspaper's European correspondent. He has won 2 Walkley Awards for feature writing, and he also worked as a speechwriter for the Prime Minister Kevin Rudd, a role for which he was awarded the 2010 Australia Day Award for Excellence in Speechwriting. Please join me in welcoming James.
Thank you very much, Sarah, and thank you all for coming tonight. I'm going to just talk a bit about the subject and then talk about how the evening will go. We're here to discuss a huge issue, a huge change in the health system, which is the rise of primary care in salience in the health system. The health system was created to address episodic health problems, infectious disease, war, accidents. And over time that has changed, especially as the population has gotten older. 90% of us will die from a chronic disease. 75% of Australians older than 65 have at least one chronic disease that is likely to lead to serious complications or premature death. And some of these conditions can be treated, but they are not being properly treated. For example, 1 million Australians have diabetes, but only a quarter of that number are being properly treated. So the consequences for the lives of people are huge, and the consequences for the health system are huge. And that's what we're here to talk about this evening. We're going to talk about 3 Grattan reports, which are a sequence of reports on the primary care system. The first of these, Chronic Failure in Primary Care, published earlier this year, really sets out the dimension of the problem, the failure of primary care to address the emerging problems, the problems that have been emerging. The second one, Perils of Place, identifying hotspots in health inequality. Thank you, Stephen. Looks at at places that have specific and acute problems with chronic illness, places in Queensland and Victoria, places such as Broadmeadows and Frankston. And it suggests a specific place-based approach to addressing these health inequalities. And the third report, which hasn't been published yet, is called Risk and Reward, and it takes the first two reports further by looking at how a new system of payment for general practitioners might help to address the problem. Now, we've got a terrific panel tonight to address this question. Stephen Duckett, who will begin by giving a 20-minute presentation on these three reports. Stephen is the Health Program Director at the Grattan Institute. He's an economist and a former Secretary of the Commonwealth Department of Education, and he's done a lot of work also down here in Victoria in the 1990s when some quite significant changes took place in the health system. Stephen will talk for 20 minutes, and then Anne Congleton from the Department of Health and Human Services will talk about will respond to Grattan's place-based proposals. She will give an analysis of those proposals. Anne is the Deputy Secretary, Community Participation, Sport and Recreation, Health and Wellbeing at the Department of Health and Human Services. Before this role, Anne was the Deputy Secretary in the West Division, which starts in Geelong and goes to the border, between 2012 and 2015. She's worked across many parts of the department and has had many roles in the department, but also before that in the departments of the Department of Treasury and Finance. After Anne speaks for 10 minutes, Professor Jane Gunn will look at the specific challenges for GPs in responding to the problems in primary care. Jane is the Foundation Chair of Primary Care Research and is the current head of the Department of General Practice and the Deputy Head of the Melbourne Medical School at the University of Melbourne. She's also a general practitioner herself, and recently she's taken a role as a Director of the Board of the Eastern Melbourne Primary Health Network, and I'm sure Jane will talk about that this evening in terms of the on-the-ground experience that she's acquired in those roles. So, and after that, we'll have about 25 minutes for questions, and we really want to hear from you. There have been some questions already sent to us, which we will also put to the panel, but we want to hear from you about what you want to know and what you feel, bearing in mind that we'll keep, please, no long statements. We want questions to give as many people as possible a chance to participate in this debate. So, Stephen, can I ask you to come up and start our conversation? Thank you.
Thanks, James. And I too would like to acknowledge the traditional owners of the land, the Wurundjeri people of the Kulin Nation, and to pay my respects to the elders past and present. And also to remind us in an audience, a health audience especially, that the disadvantage suffered by Indigenous people is such that their life expectancy is about 10 years shorter than the life expectancy of non-Indigenous people. And so when we hear those acknowledgements of country, we should always bear that in mind, that it's just not a rote thing, but it's actually a commitment of ours to actually do something about it. So as James said, we're talking about a few reports, and so I'm going to talk about some of the background, and some of it has some statistics in it, and also some of the strategies about payment and place type solutions that have been put forward. So we're talking about two reports that we've released this year, actually. The one is chronic failure, and the other is the Hotspots Perils of Place report. And so both of those are available on the Grattan website. So the chronic disease can be looked at in any number of ways, and one of them is that it's going to cost the economy a lot more in the future than it does now. And so what we see on this slide is how much money is spent on chronic disease, on particular chronic diseases, starting with cardiovascular disease, and the orange bar is how much we spend now, roughly, in millions of dollars or billions of dollars, and what we will be spending in 30 years' time. And so across all the diagnostic categories here, the three big ones are all to do with chronic disease, and you can see the significant growth that's going to occur in what we spend. And so what we have to be thinking about is it possible to change those trends, to change that pattern of future expenditure? We spend a lot now on primary care. In fact, about 9 billion or so, 7 billion or so is spent on MBS expenditure. The vast majority on fee-for-service payments to general practitioners, with some other money, a little bit of money that adds up actually quite a lot in terms of chronic disease coordination payments and mental health plan payments and health assessments and what are called performance incentive plans and practice incentive payments and service incentive payments. But this is looking at it a different way. Of those little bits of money that add up to quite a lot, you can see that there's, because of the date of this, we still have the Medicare locals here, but you can see there's quite a bit of money which is already spent on specific payments for chronic disease. And in our paper on chronic failure, we suggested that those payments ought to be redirected because they don't seem to be doing the things that we would be hoping that they would do in terms of delivery. And in our paper on chronic failure, we used data from Medical Director, which is a practice software that most GPs in fact use. And this is from a sample of general practitioners, and the data have been cleaned up somewhat. But you can see that in terms of the percentage of patients who had, percentage of people with diabetes who had particular values recorded in the software, only 60% of the people with diabetes had glucose recorded, a smaller proportion with BMI, blood pressure, and in terms of all of them, if you had all three recorded, it was only 15%. And of those who had the data recorded, not all of them were within the normal ranges. And so this is a sign that we need to be doing better on either recording or on delivery or both. And importantly, if you look at what GPs say they do, if you look at, say, the community prevalence of smoking, about 20% of the population still smoke, and roughly 20% of the people who present to GP smoke, roughly, but only 0.6% of them actually had smoking cessation advice recorded in their record. And the same sort of pattern of quite significant difference between the community prevalence of an issue and the recording of something by the general practitioner to do something about it is there with significant differences. So obviously, if you're on about trying to change behaviour, you've got a limited number of levers that you can use, of interventions that you can use. And some of these are bottom-up or from the communities, and some of them are top-down. So of the top-down interventions, one of the ones that is used a lot in the primary care sector is to talk about it. And this was particularly the case with the Medicare locals, where the ministers went around saying, Medicare locals, we're going to do everything and fix the whole healthcare system. So there was big talk on what was going to help things. Also, the Medicare locals themselves, primary healthcare networks, were again seen as a strategy for trying to change the way primary care worked in this country. The creation of what are called meso-level organisations, mid-level organisations between government, working at the state or national level, and primary care practices working at the local level. And so those meso-level organisations were going to fix the whole problem. And of course, there's this cartoon which basically has two scientists standing there at a blackboard, so you can see the date of it, and you've got the equations over here on the left, equations over the right, and then a miracle occurs, and one says, I think you should be a bit more explicit here in step 2. Well, that's the story about primary healthcare networks and also about Medicare locals. They were going to be the miracle that was going to fix the big problems on either side of them. And so here you have a third lever is financial incentives, and the issue is fee-for-service versus capitation or annual payments. We also have provision possibly of new services, also provision of feedback, collaboratives, data sharing, and so on. Also issues about community education, and so on. And the issue about this is, what I'm trying to say with this slide is there are already multiple interventions playing on different sorts of ways of trying to change practice. Not all of them are coordinated, and not all of them have been put in place to long enough to actually affect change. And so in our report, Chronic Care, we said, and here's a long list of things that need to be done. You need to have regional health systems like the meso-level organisations. You need to actually have a performance framework. You need to have care pathways so there's clarity about what needs to do and how primary care and acute care need to interact. But if you think about it, two of the very important components of that long list are alignment of financial incentives. So instead of rewarding individual separate visits and individual separate interactions between a patient and a general practitioner, you reward continuity of care, you reward looking after someone adequately for a 12-month or a 3-month or a 6-month period, and to have some sort of quality and performance framework that goes with it. And secondly, that because the change we're talking about is quite significant and indeed is so great, you need to actually plan the implementation over a long period of time and to phase up into that implementation. Now, what you need to do to change general practice, and this is another slide from the report, is that you need all of these things to be working on changing the way primary care works. And the very important message we're trying to say here is there's no quick fix. It is not, if it was a simple problem to fix, it would have been fixed a long time ago. So what we need to do is a host of interventions that all ought to be working in the same direction. We ought to have a clear strategic direction for achieving them, and we don't have that at the moment. Moving on to one of our other reports, is this issue of if primary care is working well, maybe it will reduce the number of admissions to hospitals, and in particular what are called either potentially preventable hospitalisations or ambulatory care sensitive conditions. But very frequently you hear politicians going around talking as if we could prevent all of those. And so you will see the rhetoric like there are 6% of all hospitalisations which are ambulatory care sensitive conditions or potentially preventable hospitalisations. And if we use asthma as an example, and this is national data, you'll see that there are many admissions which are same day, some which are overnight, and some of which actually are 29-day admissions for asthma. Now, it is unlikely that primary care interventions in the last few months would have stopped a 29-day admission for asthma. So not all of these clearly are preventable with good primary care. Some of them might have been preventable with good public health interventions 5 years ago. And so when we think about what are the savings from good primary care interventions, it is not a simple matter of just adding up all of these asthma admissions, for example, and say they're all preventable, because they are not. So that's sort of a sketch of the problem. And now I want to talk about two sketches of solutions. One is to say, well, we know that people who are poor have more admissions to hospital for potentially preventable hospitalisations. Let's just fix that problem. And another one is let's just fix the payment. So that's where we started from. And this is an American journalist who, amongst other things, said, the explanation is this: they have existed for all time. There is always a well-known solution to every human problem, neat, plausible and wrong. Well, that's what we found in both of these reports. A guy called H.L. Mencken, and he was trying to explain why sometimes you're able to write very innovatively and sometimes you're not. And peculiarly, of course, he found it was all to do with bowel obstruction. But that's, so when people use that quote, think about that. Anyway, so what we did was, for both Queensland and Victoria, we looked at admissions to hospital for these potentially preventable hospitalisations, and based on where people live, wherever they went to hospital. And we're looking at could you predict them, or how consistent were they? And what this graph shows is if a postcode, in the case of Victoria, had a high rate of admission to hospital for potentially preventable conditions, there was only a 50% chance that they'd still have a high rate next year. So there's a lot of volatility in those postcodes about whether they had a high rate of admission to hospital for potentially preventable hospitalisations. And by a high rate, we mean 50% above the state average. And the same sort of pattern applies in Queensland. And if you look at that graph, you can see it's only after about 3 or 4 years that you get stability in that graph. That is, it's only after an area has had high rates for a few years that you can think, yes, they'll be high next year. And the importance of that is that if you're going to intervene to do something about those high rates of admission, if you choose your areas based on 1 year of admissions, you've got a high rate of being successful simply because of random variation. So you can put up the flag and say, we actually did wonderful things and half of the areas are no longer high rates of potentially preventable hospitalisations. The interesting thing about that is the advice the Commonwealth Government gives to the primary healthcare networks is all about 1 year of data. So if they follow the Commonwealth's advice about how to set priorities, they are doing absolutely the wrong thing. And this is the map of where people were, the areas that have high rates of admission for 10 years in a row. So these are no longer random variations. These are every year for 10 years, more than 50% above the state average. And you can see quite high rates, many places with quite high rates across Queensland. But here in Victoria, that's, oops, if I can get this to point, that's Broadmeadows, Frankston, and other areas here. One of these areas is Colac for dental care, high rates of admission to hospital for dental disease. Interestingly, Colac didn't have fluoridation for much of that period. So some of these are public health reasons. They're ending up with high rates, and some of them, this is one downwind from the Latrobe Valley. So you've got a series of places where there are entrenched and high rates of admissions for a long period of time. That's just a bit more, so you can see, as I said, Broady and Frankston and so on. But another thing we looked at was, to what extent was it the same person coming back to hospital every day? You know, readmissions, were readmissions a problem or not? And in this graph, every separate bar is a separate person. And what you can see is, in the case of Broadmeadows, for example, only about 20 to 30 people here represent a third of all admissions from Broadmeadows and Corio. And so a lot of the problem, if I were looking at these areas, a lot of the problem is to do with readmissions. But down here, in these places, there's almost no readmissions, and so it's not a readmission problem. So what we're saying here is that different places have different problems. And so it's not, you cannot have a one-size-fits-all solution to these sorts of issues. That is, the response has to be a locally driven, locally developed response to dealing with these very, very high rates of admissions. This slide is an interesting one. We started this process thinking that all of the ambulatory care sensitive conditions, all the places with high rates were going to be low socioeconomic status areas, and that all the low socioeconomic status areas will have high rates. Well, as it turns out, yes, if you look at it, if you're a low socioeconomic status area, more of those are in fact areas with high rates of admission to hospital for potentially preventable hospitalisations, but there are a few high socioeconomic status areas with high rates. But also interestingly, there are some postcodes which are low socioeconomic status which didn't turn up in any of those 10 years. So Sunshine is down here and Broadmeadows is up here. So what is it that is happening in Sunshine and what is not happening in Broadmeadows is really quite an interesting question. And, whoops. The other point we found with this report was that the areas that this is the group of postcodes, 20% of the postcodes account for, oh sorry, this is a different issue. So moving on to risk and reward. So this is that graph, which I'm trying to bring up again, is that for people who have at least one chronic condition, 20% of patients accounted for 50% of all GP consultations. So they're very significant users of a GP practice. And so what the general conversation now is about is we've got to think about paying differently to rather than rewarding fee-for-service, rather than paying on the basis of fee-for-service, which has some strengths. It does lead to better accountability to the patient and so on, but it also has some weaknesses. And so what we've got to think about is we ought to have a system which tries to get the benefits of both of those things, of fee-for-service and of capitation or annual payments or continuity of care type payments. And both of those systems of payment have strengths and both of those systems of payments have weaknesses. And as I said, what you've got to do is try to minimise the weaknesses. And so there's now a lot of discussion about moving towards capitation payments for general practice. So you pay the general practice a sum to look after the patient for a whole year. Now, one of the problems in designing the policy for this is you have to actually identify the patient population. In the Commonwealth trial that they're talking about for primary healthcare homes, it's people have to have 2 chronic conditions. And you have to work out what services are included in the capitation payment. Is it just the general practice consultations? Is it pharmaceuticals and diagnostics? Is it home care services? Is it hospitalisations? So you have a number of choices about what you bundle into that payment. You also have to actually have good enough data to actually design a payment, because you want to pay the general practice more for looking after more complex patients than for looking after less complex patients. And we tried to look at this, and so we took our data and we had about 60,000, I think, consultations, and for the whole data set, which were people with more than one chronic condition, on average, these people with one or more chronic conditions, they averaged 7.8 consultations in a year. And using statistical techniques, you can split that, and for people under 70, they had on average 6.4 consultations, and people over 70, they had on average 11 consultations. And if they had one consultation, they'd have on average, one condition, they'd have on average 5.9 consultations. If they had more than 2, they'd have on average 14 consultations. And this is the way you develop a classification system in the hospital scene called diagnosis-related groups, and so you can do exactly the same with general practice consultations. And in fact, you end up with quite different distributions. So this is the graph of this one, people under 70 with only one chronic condition. The average here is 5.9 consultations in a year, but you can see there's pretty much of a tail, but it's skewed in that way. And this is the graph for people with over 70, more than two or more chronic conditions. 14 consultations is the mean, and again you see quite a different distribution. And so you can see why the statistical program split it in that way. On the other hand, when you put them together on the same graph, you see there's a huge overlap in those two graphs. And in fact, going back to this tree here, it only explains 13% of the variation in the number of consultations, which in our view is not enough to be used as payment. So you have to have better explanatory power. And what's important is the data we used in this analysis is more than the data the Commonwealth has available to it. It doesn't have diagnosis, which we had in this data set. So what we're saying is there's a lot of work that needs to be done in actually developing the payment, and we think it's a bit too early to actually talk about it. So we don't think that condition is met. Certainly we don't have good performance indicators in general practice, and certainly we don't think the capacity of practices to actually develop to manage in this new system are there at the moment. So unfortunately our view is that we've got to be wary of jumping on bandwagons about what is the right thing to do, and the evidence base for all of what needs to be done is very weak, so you have to proceed with a lot of caution. And as we said before, there's always a well-known solution to every human problem: neat, plausible and wrong. Thanks very much.
Good evening, everyone. I would like to start today by acknowledging the traditional owners of the land that we meet on today, the Wurundjeri people and the neighbours, the Bunurong people of the Kulin Nations, and pay my respects to elders past and present and any elders of other communities who may be with us tonight. Thank you very much for the invitation to join tonight's panel. I just wanted to acknowledge the work of the Grattan Institute in producing the report and to shine a light on an area of significance, not just from a health policy point of view, but more broadly from a social and economic policy point of view as well. I'm going to talk a little bit about what we see in the department in the data that Stephen has presented, what our thinking is in terms of how we address the issues that presents, and also some reflections and observations on that. So I suppose just starting from the Department of Health and Human Services point of view, at the outset, improving our understanding of the reasons behind the geographic variation in health and wellbeing is really important to the department. And people are probably aware of the Public Health and Wellbeing Plan, which has as its vision a Victoria that is free of the avoidable burden of disease and injury, so that all Victorians can enjoy the highest attainable standards of health, wellbeing and participation at every age. So for us to achieve that, then we must tackle where inequality exists. The department as well has undertaken some work a bit similar to what the Grattan's work has presented, and we'll be doing some further analysis picking up on the Grattan work. So we've heard from Stephen about the areas, the geographic hotspots, as we call them, where rates of potentially preventable hospitalisations are persistently high. And as we heard from Stephen, that the report found that disadvantaged areas, and in fact some figures that have been presented, were 2.5 times more likely to be hotspots than all areas on average, requiring tackling on a number of fronts when we think about areas of disadvantage. It is, though, I think, important for us as we do that further analysis to also look, as Stephen's just mentioned, that not all areas of low socio-economic status areas were hotspots. So, what is happening in Sunshine, as Stephen mentioned, I think will be equally important. So some of the findings that have come through the work and the analysis that the department has done, and again, there's a lot of connections with the Grattan work, that the potentially preventable hospitalisations are strongly associated with access barriers. So therefore, what that means is that the higher the access barriers, the higher the rates of admissions of potentially preventable hospitalisations. We also heard about the correlation with socio-economic status. There's also a significant link with poor self-rated health, as well as there is a correlation in rural areas. So just thinking about that data then, and then thinking about the department's role and direction. So there are 4 strategic drivers that will be sitting in our strategic plan for this current financial year. So our efforts are really going to be focused, and remembering again that we're the Department of Health and Human Services that cover and they focus on person-centred services and care, local solutions, earlier and more connected support, and advancing quality, safety and innovation. And there are a number of elements that sit across that 4 that we need to bring together to address the challenges that have been articulated through the Grattan report and the opportunities that a place-based approach presents. Many of you would be very well familiar with the Latrobe Valley and also the government's response to the Hazelwood mine inquiry. So we know in the Latrobe Valley, and we saw some of these statistics in terms of the health and wellbeing of the community. So there is a focused response that has been announced through the government's response to the Hazelwood mine fire inquiry that is really going to give us the opportunity to have really focused effort and intervention and in the Latrobe Valley. And our starting point with that is very much making sure, and this is something that has to be a feature of any place-based approach, is that it really needs to be driven from community to marshal the local knowledge, leadership, ideas, expertise and resources And for us in the Healthy and Strong Latrobe, that will be through the creation of the Latrobe Health Assembly, which is kicked off today with a task force. So there's also, I think, as part of this, and again, not just thinking about it from a strict health point of view, but thinking about it from a broader point of view, that we need to tackle the issues across a number of areas. So we just don't have a lens on health and hospital admissions, but we also know in places like Latrobe the importance of education, of jobs. We also know that there are issues around child protection, so thinking about things from a holistic point of view is really critical. So it is requiring agencies, community service organisations, government departments across local government, state government and the Commonwealth government, and with our primary health networks to work together, and that is an important prerequisite. It's really important to also then think about what is it that, what is the local intel, what do we need to change at a local level, and where might there need to be some interventions that really sit at that whole of population point of view and whole of state point of view. Investing in prevention and early intervention is really important, as well as we've heard about interventions in the primary care space, and recognising that investment in additional services is also part of the picture. Another important frame to place-based approaches is being really clear on setting the outcomes that we're trying to achieve collectively, and to track those, and also to report on our progress. I really believe that place-based interventions tailored to local communities are keys to addressing the issues that we've seen that have been highlighted by the Grattan report. And this approach will also facilitate a focus on particular population groups. So when we're looking at a place, our capacity then to think about who is in that place, and we recognise that not just for some places, but even for some population groups, their health outcomes are not as great as the state average. So the chance for us to be thinking about whether it's around Aboriginal people and communities or refugees, it offers us that opportunity to sort of really drill in and to understand what interventions work for population groups as well. But I think, as Stephen mentioned, we can't take a cookie-cutter approach to this. That the barriers and issues may be different in different places and for different people. We've been doing a lot of work with Aboriginal communities as part of the development of a new Aboriginal health, wellbeing and safety strategic plan for the department. And there is a lot that Aboriginal people are telling us about, what is it that they need and want to see in terms of our responses. So they talk about holistic approaches that consider the cultural and social determinants of health. They talk about the importance of cultural capability of organisations. They talk about some of the barriers that they confront, and that is around barriers of stigma, discrimination and racism. These are critical barriers to access to good health and good human services, and that those things need to be averted and to be tackled. So I think, it is a reminder that in place and local solutions, we need to listen really carefully to what communities are telling us that they need. So it will be important that we learn through our local place approaches, that we adapt, and as we learn things that we can apply those things, but how we then use that information to inform other responses in other places and our policies more broadly. So critical to this will be rigorous evaluation on the interventions. So recognising that, particularly as we approach what we're doing with the local community down in Latrobe, what are those things that are yielding best outcomes, rather than all being mixed together. So being able to differentiate that will be really important. So we can see what works and what we can apply to different places, and what in fact is quite unique to that place. The approach, I think, will continue to provide challenges, as it is already to us as an organisation, to think about how we work. So we can think about doing things in a different way, but there are challenges for organisations to think about how we connect with communities, and how we lead centrally but on the ground, which is really quite critical. So I think that any approach from a place-based point of view really does require enduring leadership, persistence, and I think, as Stephen pointed out, that to get change and shift in places where there are those hotspots, it is going to take time. So continued focus and energy over a long period is quite critical. I'm really excited by the opportunity that is presented by our work with the La Trobe community. I think that there is much for us to be learning from the community as bureaucrats, and I think there's a real chance for us to make a difference in that community, but not just in that community, but in other communities as well. And I'm certainly happy to take questions or comments and to explore this in a bit more detail when we have the panel session. That's it from me.
Okay, thank you. Well, I'm going to take a slight diversion now and just talk about getting primary care right from the general practice perspective. So from place back to the general practice. But I'd like to start by acknowledging the traditional owners on the land upon which we meet, their elders past and present, the Wurundjeri people, and just to make note that we can learn a lot from the way that Aboriginal health services have actually tackled some of these problems around the country, and we can perhaps take that up during the discussion. But I'm sure some of you have been on the road to the Medicare local journey. And will it have a happy ending, Melissa Sweet wrote some years ago. Well, the happy ending has been the development of primary health networks. And now, of course, the focus is on PHNs and whether or not they will deliver. As James said, I'm on a board of directors of the Eastern Melbourne PHN, but anything I say here tonight is not representative of that organisation. They're my own opinions. I'd like to think that the involvement of general practice is key to the reform, and certainly one of the elements of the revised version of meso-level primary care organisations, now called PHNs, is an attempt or a recommendation that they engage with general practice. This was seen to be an area where Medicare locals didn't do well. I think that is a generalisation and maybe not evidence-based. But certainly now it's explicit that general practice is key to reform. So what is general practice? And part of, I've been involved for 25 years in primary care research at the University of Melbourne, and it sort of always occurs to me that people are a little bit reluctant to engage general practice in really getting into the nuts and bolts of reform, and almost try to work every way around it rather than tackling it. And I'd like to bring that to our attention tonight. General practice has changed dramatically over the last 50 years. But in recent times, it's gone from solo practices to group practices, and the number of practices has reduced. At the same time, we've seen the number of GPs increase slightly, although there's only about 18,000 full-time equivalent GPs across the nation. There's some things that we have to think about at the professional level, that there's increasing pay gaps between GPs and specialists in our healthcare system, and this has made general practice not necessarily the career destination that we'd like it to be if we're going to tackle these important problems. We've got increased relying on overseas trained doctors to come often to our places of workforce shortage and do the jobs that a lot of the local doctors don't want to do, the locally trained doctors, and increasing corporatisation around about 50%. The figures are hard to get. This is a context that we must be really aware of if we're going to try and reform the healthcare system. And then when we say, well, is general practice all the same? Well, no, it's not. Across those 7,000 to 10,000 practices, they vary enormously. Some things are very similar, though. There is no patient registration. So no practice is really absolutely certain of who their population is. Most operate on 10 to 15-minute appointments. They use medical records, electronic records, but they're not that intelligent. And I'll come back to that later. A lot of the data Stephen presented came from those unintelligent medical records. The decision support that we work with as GPs every day is very poor, and there's no routinely collected outcome data, and we don't agree on how to code anything into our medical record systems, even within our own practices. Not because we find it hard to agree, we just haven't agreed, and it's not easy to do. The corporate governance, the way that our practices are run, varies enormously from highly organised corporate organisations down to still family-owned businesses. Clinical governance is an area that is very unexplored in the general practice setting, and the infrastructure varies enormously, both in premises and information technology. The staffing, you'll see pretty similar things as GPs in general practices and lots of nurses, and these have been increasing in recent years. And you will see, depending on where you go, various levels of team organisation, from highly advanced practices to very low key. That's general practice today. I just want to remind us of the ecology of medical care, because this is very important as we try and tackle the problems that Stephen's reports have identified. For most people living in the community will be well. About 750 of us will have a grumble in the previous month of an injury or illness, and out of that group around 250 will go and visit a primary care doctor. Of that, around 9 will be referred or end up in hospital, about 5 will be referred to a specialist, and 1 will end up in a big academic institution like the Royal Melbourne or Monash Medical Centre. A lot of our focus goes on to the one person in these very big tertiary hospitals, often for good reason. But for the GP working out there in general practice, their focus is very much on the community that they see, those 250 people that walk through their consulting room each day. So this is a context that we have to be very aware of. So what are we trying to change it to? What does strong, effective primary care look like? One of the challenges is that there's lots of models around the world, but what are we going to do? What's our plan for Australia? And this is something that is not clear. There is no blueprint for what we're trying to achieve as general practice. So I'm going to put forward to you that I think there's 4 essential functions of primary care that we need to think about, and I'm sure there's many other things to put into the mix, but just for the discussion tonight, I think that it really is about entering into the world of the GP and using that little enter mnemonic. It's about evidence. The practices have to have the capacity to access, use and improve upon evidence for every one of the consultations. They have to have the tools to navigate around the healthcare system and to track people's way through. There's the essential capability of engendering trust. If our community is not at the heart of this healthcare, if the patient is not central to what happens, this whole endeavour will become undone. Trust is essential. And the primary care has to have the function of reflection. It has to have a culture of reflecting on what it does at every level. And I think these 4 elements are key. I think that they can be grouped into the aspects of what you will read about in all the literature, and I haven't bothered to reference any of it, but if you go and you look at primary care reform, you'll find all of these elements. But you'll see we are really lacking in our medical record systems that we have in primary care, in the way that they're intelligent, the way that they should be helping us do our work. We really need to have patient registration so that we can help people navigate around the healthcare system. We need to be able to have excellent information flow in all directions, and people accessing care needs to know what's happening for them and to them and with them, and that's so important as we redesign the healthcare system. Trust is also so important around the way that people are communicated with, the way that those encounters happen. We cannot ignore the fact that healthcare will still, we want it to be a personalised experience. And reflection, the annual team profiling, the way that we fund, the continuous quality improvement, these aspects are all things that we need to do. I would put to you that most of the things up there on the PowerPoint slide exist at least in embryonic form in our system here in Australia, and we do have foundations upon which to build. But I think that we're at risk of not building on them at all and trying something completely different. So, what is it ready? Is primary care, are the general practices ready for this transformation? Well, this is the Commonwealth Fund data, which I'll just finish up on. And you'll see that Australia's in the middle here. This is from 2015, last December. We could argue about the methods used for the Commonwealth Fund, but nevertheless, around about half of the GPs responding to this survey are ready for fundamental change. So 1 in 2, that's great. I think that means the soil is fertile for change. But is it that simple? No. Here's an example. Here's one example why it's really hard to make the changes Stephen is talking about. We have been early adopters of electronic medical records in Australia as GPs. We're well ahead of our hospital colleagues. We've been using them for more than 20 years, and we can right up at the top of the world in our use, and it's consistent. If you ask the GPs whether or not they think they're good records, you find 80% of them think they're very satisfied or satisfied with the electronic medical record. Well, I just think we're too easily pleased, because I think they are not doing the job well enough for intelligent healthcare in this technological age. But if the GPs think they're great, then how are we going to convince them that they need to do things so differently? Therein lies the challenge. I want to end by one of my favourite diagrams for medical student lectures. This is how boring they are these days. But this diagram, to me, sort of says it all. Often this is where we have to have change happening. The individual GP patient. I think the patient is at the heart of healthcare, or the person is at the heart of healthcare. And they have to be the focus on which this system reform revolves. They have consultations with the GP every day in the consulting room and out of the consulting room more and more. Email, contact phones, telemedicine, e-mental health, all of those things. But one of the things I've seen over the 20 years plus watching what's happening in reform, often all of the activity happens above that line, and very little gets down to actually tackle the problem across the 7,000 practices that are the functional units of the primary healthcare system in this country. And that is the challenge for PHNs. They must enter in to what's happening in that practice. It cannot be done totally from above. Now, the levers that you might use are interesting, but the activity that changes has to happen inside those walls, or else we'll still be here in another decade talking about exactly the same problem. Thank you.
Thank you, Stephen, Anne and Jane, for three terrific presentations. Just before we go to questions from the audience, I wonder if Anne and Jane, you could reflect on, to try to pull this together. Stephen is working towards place-based approaches for those areas that really have high rates of potentially preventable hospitalisations. And he's looking in this final report, which has not yet released, on the possibility of what they call a capitation model versus a fee-for-service model. A capitation model being payment for one patient over a period of time. And of course, there are different challenges with that. I wonder if you could both reflect on those two aspects, specifically of Stephen's and Grattan's work. Are they the right ways to go? And what specifically would you like to see Grattan focusing on in those areas? Anne?
Gee, that's a doozy. I suppose for me, just to sort of think about coming back to, I think primary care is obviously a key part of addressing those issues, but they can't do it alone. And I think that for primary care to work effectively, and just reflecting on the slide that Jane presented in terms of what's important from a GP perspective, I think it's to get traction, it's really got to be about the relationship that the GP has with the person. So I suppose when we think about, whether it's funding, is it a sort of, quick fly through, or is there that chance to sort of see what that person is coming up with now, but also then having that relationship and trust then to think about what other things that person may need. So whether that, helps sort of the churn or the comeback. So just in thinking about then the capacity to think about the relationship and having an element of that goes beyond that, just what they're there for at that point in time.
Thank you.
I'd probably think that the way to, say, look at the areas that have shown up as the very big hotspots, one of the things that would be a good starting point is to actually look at the practices within that hotspot. It won't, because we don't have people registered necessarily with the practice in the hotspot, I think there's still a lot of alignment between where people live and where they seek medical care, although we should be able to answer that very precisely and look at where the people are that are having those frequent admissions. And there should be good communication between the hospital and the practice. And a practice should know whether it's got a higher number than average of that. In the same way that Stephen's done the report for the country, practices have to think about that at their own level. And being able to do that means you've got to have the reliable data systems and collection methods and everything to be able to even look at it, to even guess at it. I'm jealous of other countries because they do have this often in place already, so it is possible.
Thank you, Jane. Stephen, do you want to quickly respond? Or? Yeah. Okay. Okay. Let's have some questions. Who would like to start? There are roving mics, so please wait until the person has arrived with the roving mic. Over there first.
I'm very interested in the readmissions data, and I'm just wondering if there's any data about early discharge and insufficient support in the home when people are discharged from hospital, because I see both of them are really two sides of the same coin.
We didn't look at that. We didn't look at the factors associated with the readmission, whether it was length of stay related or not. There has been one study of that kind in Australia, and it came up with quite mixed results. In some cases, shorter length of stay was associated with higher rates of readmissions, and in some cases it wasn't. At the Council of Australian Governments meeting on the 1st of April of this year, the heads of government, Prime Minister and the Premiers and the Chief Ministers agreed that there would be financial incentives incorporated into the hospital funding arrangements associated with readmission rates to come into effect on the 1st of July 2017. But we didn't look at that issue in that report.
Jane, do you have any thoughts on that, on the lady's question?
Not really anything to add on that one.
Question at the back there, the lady with the white scarf.
Just a quick question about the hotspots. Was there any correlation? Obviously you said there was socioeconomic correlation, but was there any correlation with the number of doctors, with the number of practices in the area?
Yes, we wanted to do that, and we got a data set from we got two data sets from the Commonwealth Department of Health. One had age and sex in it, and one had geography. So we couldn't do an age-sex standardised rate because we had two separate data sets, but we couldn't do the analysis.
Yes, right up the back, the gentleman. Yeah. If you just wait for the microphone, because we're recording this, if you could just wait.
No, it's behind you, Rod.
Just a question for the panel, maybe Stephen. To what degree do you think the demarcation issues between Commonwealth and state funding play into some of these issues? And can you see primary health networks as a means of actually maybe better integrating funding, or is maybe reform just dead?
You're such an optimist. I'm actually more of a Pollyanna on these sorts of things. So my view is that primary health networks are the only game in town, so we've got to use them. And also, even though the Commonwealth Government treats them as creatures of the Commonwealth Department, they are in fact independent incorporated entities. And so my hope is that over time they'll be regarded as a neutral space which both the Commonwealth Government and the state government can use. That will require the Commonwealth Government to liaise with them and hold them accountable more for outcomes than for inputs, and they're very micromanaged still at the moment, is my view. And so if they want to be a neutral space, if we want to use them as a neutral space between the Commonwealth and the Commonwealth has got to change its behaviour. But the state has also got to say, these things, yes, were stimulated by the Commonwealth, but we can use them too. And as I said, my view is that they are the only game in town. One of the good things about the hospital funding arrangements is the Commonwealth is on the hook to pay for 45% of the costs of increasing hospital activity. So it's in the Commonwealth's interest to try and develop the primary care system to reduce the growth in hospital demand. So they have a financial incentive too in terms of trying to moderate hospital growth. And so I think the financial incentives are working in the right direction, that should mean that the Commonwealth is interested in doing the same things as the state is doing. So even though we've got quite a complex system, the financial incentives are working in the right directions.
Just before we take another question from the floor, we've got questions that have been submitted to us as well. Jane, this one's for you from Professor David Pennington, former head of the University of Melbourne Medical School. And he asks you, do you think the primary health networks have the necessary professional leadership, both centrally and at the local level, to tackle the problems?
That's a very good question, I think. I'd probably respond by saying that one of the things that's lacking, what's going to help in terms of leadership for the reform that we need, is a clear idea of where we want primary care to head and the sort of primary care setting that we're trying to develop. And in particular, I think we need to look at that in terms of what sort of practice do we want to be available at our local level and across the country, so that we have a clear idea of the type of primary care that's going to, and obviously it's not going to be one size fits all, it's got to meet the needs of the local community, but having clarity on that would be very good. I think there is a place for national leadership around some very important areas, and in particular I would put that around electronic medical records, data and decision support. That's the kind of thing that's expensive to do well, it's hard to do well, and there's no point doing that at every individual PHN level. It's just too difficult. Even to do it at a national level is hard. So I think leadership around that is very important, and around outcomes and indicators at the high level, although every PHN will need to develop things for themselves that are very relevant for their own context at a local level. So I think leadership is important beyond the individual PHNs that exist, and that bit is not clear currently.
Thank you, Jane. Another question from the floor. If you have a role that's relevant in the health system, you might introduce yourself when you ask your question. The gentleman there over in the right.
I'll let others judge whether I've got a role in the health system. My question relates to Stephen Duckett's presentation, which I thought was very good. And you had a particular graphic there which showed the hotspots spread across the different SES areas, in Victoria and Queensland. And they show that we're hotspots, warm spots and cold spots across each of those SES areas. My concern is it's all very easy to concentrate on the hotspots. What's translatable from a warm spot or a soft or a cold spot to a hotspot? Why is it that hotspots remain hotspots for considerable periods of time? What lessons can we learn, and what additional work needs to be done to be able to establish those transferable learnings from a cold spot to a hotspot?
So that was one of the two really interesting things that we found. So we thought, right from the start, it's all going to be socioeconomic status, and all socioeconomic status are going to be, but it's not. And it's this Sunshine versus Broadmeadows issue that really is interesting. When, to my experience, having worked a little bit in both of those areas, the social determinants of health, if you like that phrase, the socioeconomic factors that would lead to elevated rates of hospitalisation, potentially preventable hospitalisation, are very similar, and yet they're not. And so I think it is, and there's a lot of areas of this kind. And so I think the question you raise is, we couldn't analyse that from where we stood. We didn't have the data to do it. But our conclusion was there are local factors that what is it locally? Is it that there are more GPs in one or not? As I said, we couldn't look at that. But no, we don't know the answer to that, but you're absolutely right. It's one of the critical questions because they're only, 10 kilometres apart. We should be able to learn from one to the other.
Yes, the gentleman.
Thank you. My name's Stan Cap. Forgive me if I've misinterpreted the data that was put up, but it seems to me that there's a huge amount of money that's going to treat chronic disease management. And I'm interested in how we can improve that and how we can actually focus in on something that actually can change without waiting for the miracle to occur. And so I'm interested particularly in Jane and Stephen's points of view about how in fact you can do something to enable this incredibly high amount of money that we spend with, at best, poor outcomes being demonstrated and at worst, very poor outcomes.
I think there's high level and low level things you can do, high lens and low lens. I'll leave the high lens to Stephen and I'll take a low lens anecdote. An example from my own clinical woman I saw this morning is someone, a single parent with diabetes. I've known her for 20 years. I've seen her child grow up. I've been with her throughout struggles to get her health in order. And she has tried hard against all sorts of odds. But recently, one of the really difficult things has been able to be getting her into a supported environment where she would be able to just do some physical exercise that's really needed, which she's needed for 20 years. But finally, she has been able to get this really coached physical exercise because through the care plan, she'd get 5 of those a year. That's nothing. I mean, it was just gone before she'd even started. She had to split them up between the dietitian and the exercise physiologist. So she's finally made a huge commitment for money she doesn't have to spend it on an exercise physiologist. And she's actually making gains for the first time in those 20 years. Now, I think the chronic disease management it is as tailored as that. It's as tailored as understanding what each individual needs and then the financing system being able to allow the primary care practice to deliver that somehow. If I could have given her an exercise physiologist 20 years ago to coach her once a week, I would have given it to her then. But it was impossible to get. And so she's had these little sprinkles of intervention over 20 years where she's got bits and pieces of programs and projects and things that have been funded from various community health centres or a bit of state government or, a bit of the chronic disease management plan. I think what we've done is spread too much too thinly across the system. Too many people have chronic disease management plans and all of the things that they probably don't need because they're not at high risk like this woman is. She needs 26 visits or 52 with an exercise physiologist for a few years. And I can then, she could conquer her diabetes. That's the low level example.
So thanks, Dan. Just following up on Jane's comments, so there's about $1 billion spent on that chronic disease management items and the like, and general practice gets the same amount for a person with well-controlled diabetes, no real problems with a person like Jane was describing. So we've got to do some sort of tailoring and focus or risk adjustment to use the technical terms, and that is actually quite complex, and we haven't started that process. And as I showed in our work that we've just started to do, we don't have the data to do it well enough at the moment. Another anecdote of the same kind is that I was in London a few years ago now, and I was looking at CarePath software, and the particular CarePath software I looked at had the GP could use the CarePath to refer people off to an exercise physiologist, but they'd also had tailored it so that they could refer it to a local exercise group or a local walking group that the local council had actually organised, and the data for that was in the care management software. So it was not putting them off to a health professional, but putting them off to local community support services, which were A, group activities, and B, locally available. So going back to the the high level or the broader system changes. Yes, we need to change the way we think about payment for general practice. At the moment, every problem has a fee-for-service solution. The way we've evolved our payment system has been to graft on and graft on and graft on, and each time it is making the fee-for-service system a bit more complicated and adding a few more items, rather than stepping back and saying what is the right thing to do and how can we do it. And one of the problems with the Commonwealth primary care healthcare homes trials is that A, they're very small, very few number of general practice, but B, they haven't stepped back. And as Jane said in her presentation, what is the overall vision? Where are we trying to get to, and articulate what it is, and how do we know that what we're doing here is path of the way to get to that? And it is going to take a long time because it is a big system we're trying to shift, and the evidence base isn't as strong as we'd like it to be. So it is using what we've got and using it better, but it also, as Jane said, needs to be setting a vision that is very clear.
Anne, would you?
Yeah, I just, as I listen to Jane and Stephen, what goes through my mind is reflecting on the disability services system through the development of individual support packages in Victoria and then the National Disability Insurance Scheme. So where we're focusing on, what the outcomes are for people, providing a tailored package of support to people. And that can be a variety of things, so that there is quite a bit of flexibility in what that can be deployed to, but very much at the centre it really elevates the person to be driving what it is that they need. So whether there are some learnings from that we can take into other funding models. And I think the other thing is just thinking about the future. I think it is about then the investment in prevention. When we think about that, I think that 2/3 of Australians are obese or overweight. So there are a number of risk factors that I think we've got to pay attention to.
Thank you. And we've probably got time for just one more question. Yes?
Hi, my name's Elizabeth Liu. I haven't been involved in health for quite a period of time, but I was back in the late 1990s and early 2000. And when you said, Jane, in 10 years we might be here looking at the same issues, I think Stephen can agree, and perhaps Stan, that we were looking at these things back in that period. And I just want to know, is it really possible, if you have 7,000 individual GP practices, all established in different ways, to actually move towards a new system if you don't have capitation, or if you don't have a different way of managing data? And that's my question.
I think it's possible with the 7,000 practices. I'm not sure if that's how many we really need, but I think it's a good enough number. I think having healthcare close to your home is probably what most Australians would like to know was going to be there. So I think that's probably okay. I do think that the technological issues have to be begun to be solved, but they're going to take a long time. I think that engaging the practices in the endeavour is going to require a different funding model. Otherwise, I think that doesn't, often GPs might necessarily think, well, that will mean it'll be a funding model that means I can't run my practice, because a lot of them are running on very close figures. Others are probably making a lot of money out of the Medicare items that maybe isn't evidence-based. And I think we have to sort that out. There is a lot of variation, and a new funding model is required to do it.
So I'm an economist, so it won't surprise you to know that I think if the financial incentives aren't going in the right direction, you're not going to get the right answers. Half of the practices are big corporate entities, majority of those listed on the stock exchange. Majority of the remaining half are small businesses. So financial incentives will change the way they operate. And so that is absolutely core, getting the financial incentives right. Jane also said, there are some other things. There are 3 big providers of practice software, and there is no consistency about how you record things at all. Each GP almost has their own idiosyncratic way of doing things. Sometimes there's standardisation within a practice software, but sometimes there's not. And some of these things, the government just ought to say, after consultation with general practice, this is how we're going to map. You can record however you like, but it's all going to be mapped to this standard system that we're going to apply. Other countries have done it. The United States, for example, the home of free enterprise, the doctor themselves have to record the ICD-10 codes on the billing form for Medicare. So, and then say what this intervention was, which diagnosis does this intervention relate to? So, you know, that's the home of free enterprise and anti-red tape and mad Donald Trump. But you know, we ought to be able to have some sort of systematic collection. For people, every discharge from a public hospital, every discharge from every hospital in the country, we know the diagnosis, we know the procedures, we know what happened. We've got almost nothing on general practice when it should be, if it's going to be the foundation for the health system, we ought to know what's going on rather than what they just did.
Anne, do you want to? No. I think we're out of time. Look, let's thank our panel, Stephen Duckett, Jane Gunn and Anne Congleton for a wonderful discussion. And thank you to the State Library, Sarah. We really value this relationship with you and the Policy Pitch series. We hope it lasts a long time. And thank you all for coming tonight. Such a large and attentive audience. It's been great. So see you next time.